Choosing the right heart valve is no longer a simple binary decision based on age. It is a complex lifetime management strategy. With the 2025 ESC EACTS and the upcoming 2026 AHA ACC updates, the decision-making process has shifted more towards patient-centered variables. Here is a breakdown of the key factors for choosing between mechanical and bioprosthetic valves. The fundamental tension remains a balance between durability and safety from anticoagulation. Durability is quite long for mechanical heart valves, while it is lesser for bioprosthetic valves, especially for younger individuals. Lifelong anticoagulation with warfarin is required for mechanical heart valves, while anticoagulation is needed only short term for 3 to 6 months for bioprosthetic valves unless atrial fibrillation is present. Main risk is thromboembolism and major bleeding in case of mechanical heart valves. Structural valve deterioration and reoperation are important concerns in case of bioprosthetic valves. Mechanical heart valves have a clicking sound which is often audible to the patient, while bioprosthetic valves are silent like a natural valve. Some patients are really disturbed by the clicking sound at night. Recent guidelines have refined the age cutoffs, though a significant gray zone exists between 50 and 65 years where patient preference is paramount. Below 50 years, mechanical valves are generally recommended. Bioprosthetic valves in this group have a high rate of failure, often requiring multiple reoperations over a lifetime. Between 50 to 65 years is the debate. In aortic position, guidelines are leaning more towards bioprosthetics because of the success of the transcatheter aortic valve implantation for future valve-in-valve procedures. So surgery is avoided. Mitral position mechanical valves still show a survival benefit up to age 70 in some studies because mitral reoperations are higher risk than aortic ones. Above 65 years, bioprosthetic valves are typically preferred as the valve's expected lifespan often matches or exceeds the patient's life expectancy, avoiding the risks of anticoagulation in an aging population. Beyond age, several factors can tip the scales in one direction. Favor mechanical if the patient is already on lifelong anticoagulation for other reasons like permanent atrial fibrillation. Patient has a small aortic root. Mechanical valves often have better hemodynamics in smaller sizes, reducing the risk of patient prosthesis mismatch. The patient has a high risk for reoperation, example previous chest radiation or complex anatomy. Favor bioprosthesis if pregnancy is being planned. Warfarin is teratogenic. Women of childbearing age often choose bioprosthetic despite the high risk of early structural valve deterioration. High-risk activities like contact sports, remote travel, or jobs with injury risk make long-term anticoagulation dangerous. Patients who are older or have a higher bleeding risk, has blood score. Future options. Patient is a good candidate for a future valve-in-valve TAVI, which can avoid a second open heart surgery. Then also bioprosthetic can be considered. Lowering the threshold for transcatheter aortic valve implantation to 70 years or even 65 years in some regions is making bioprosthetic valves more attractive to younger borderline patients who want to avoid warfarin. The 2025 ESC guidelines emphasize 3D CT and transesophageal echo for earlier detection of subclinical leaflet thrombosis, which can help manage bioprosthetic valves more effectively. The newer mechanical valves allow for a lower INR target, 1.5 to 2, potentially reducing the bleeding risk traditionally associated with mechanical options. Finally, the heart team approach is now the gold standard. Decisions should be documented as shared decision making, ensuring the patient understands that a bioprosthetic valve is often a two-procedure strategy, while a mechanical valve is one procedure strategy with lifetime medication burden.